Hi everyone, welcome to the video on haemorrhagic disorders, coming under paediatrics because most often you'd see it presenting in this age group. Okay, so a few questions. Haemophilia A is a deficiency of which clotting factor? So I have a little thing about the clotting cascade and the factors involved in that. So it would be 8. So the way I remember haemophilia is A is 8 because it sounds quite similar, and B comes after A, obviously, and 9 comes after 8. So it's quite a good way of remembering it. So next question, what is von Willebrand disease? So inherited or acquired platelet disorder, or an autoimmune disease, or coagulation disorder. And try and think where von Willebrand is in the pathway and what you'd expect from this. So it's a coagulation disorder. Von Willebrand and haemophilia both come under this term, and it's the most common hereditary coagulation disorder, and we'll go into it a bit more. Fun fact of the day, it also affects dogs. Okay, last question. What is immune thrombocytopenia? So you'd often hear it as ITP, and think about the definitions and whether it come under coagulation or platelet disorder. So it's lack of platelets, and it's essentially a diagnosis of exclusion. And then 9, just as a side note, that would be haemophilia B. You may also hear it called Christmas disease. Okay, so brief overview of how it will run. What is it? We'll go through the main ones, symptoms and history, investigations, differentials, and then some tips for OSCEs, and finishing with some more questions. Okay, so before we discuss haemorrhagic disorders, we must first understand what they are disorders of. So if you pause this video quickly and remind yourself of the clot formation. Okay, so also the coagulation cascade, this is really important to learn. And again, pause this. There are loads of ways of demonstrating this. This is one I found on Wikipedia, but it's sort of individual, so if you Google it, and you'll find a way that suits you. Okay. So what is a hemorrhagic disorder? So they can either be a coagulation or a platelet disorder, and inherited or acquired. So the most common platelet disorders are thrombocytopenia and coagulation disorders, haemophilia, von Willebrand's, and vitamin K deficiency. So you may also hear this description. So primary hemostasis defect is a platelet disorder, and secondary is coagulation. The way I remember this is platelet primary, quite a good way to remember. Essentially what these are, primary hemostasis defect is a disorder of the platelets or the vessel wall, so think what comes first. A secondary defect is a disorder of the coagulation cascade, including intrinsic and extrinsic pathway. So first of all, thrombocytopenia is where you have low platelets, multiple causes. So either you don't produce enough, the body destroys too many, or the spleen holds on to too many. Medications to note are usually immunosuppressants, so valproic acid, methotrexate, carboplatin, things like that. And some cancers can cause that as well. Symptoms are sort of mucocutaneous bleeding and bruises, the petechiae and purpura, I think that's how you say it. I have a little picture of that, so to distinguish between the two. So the main types, ITP and TTP. So ITP, also called thrombocytopenic purpura, is where you have an isolated low platelet count with normal bone marrow. It's an autoimmune disease where the antibodies form against platelet surface antigens, and this shows as a characteristic purpuric rash. TTP is an emergency, so if you suspect this, get on it straight away. It's essentially where blood clots form in the small blood vessels, and it's an emergency because it can lead to renal failure. In half of the cases, a trigger can be identified, such as pregnancy or certain medications, and a very small percentage are inherited in an autosomal recessive fashion. Specific symptoms that you can look out for include a fever and neurological symptoms as well. So investigations usually picked up on a routine full blood count, and then investigating further would include a bone marrow biopsy and reviewing medication and things like that. So you want to eliminate the underlying problem, for example, if it is medication, and it also depends on the severity of the disease. TTP is treated with plasmapheresis, where you remove the antibodies, and ITP, it can be left untreated and it may resolve, but you want to monitor it and treat severe bleeding episodes. And this is a picture of the rashes that you can get with thrombocytopenia. This is purpura and that's petechiae. So they look quite similar, but it's important to know the difference. So haemophilia, it's mainly inherited via X-linked recessive, so you'll see it a lot in males. It can be acquired, but this is a very small percentage. But it is associated with cancer and pregnancy. So as we discussed, Haemophilia A is 8 deficiency and B is 9. So investigations, you have a normal prothrombin time, but a prolonged APTT with correction with a mixing study. So you're probably thinking what a mixing study is. Essentially, it's done when the APTT is prolonged. So what happens is the patient's plasma is mixed with normal plasma and the APTT is remeasured. Essentially, if it corrects, like haemophilia does, then it suggests a coagulation deficiency. And as we went through in previous slide, Haemophilia A is a coagulation defect, which is secondary defect. And it's important to note because the APTT does not correct if it's acquired haemophilia, just inherited. Also, you want to do a factor assay to look for deficiency in either factor 8 or 9. Management, you want to have a plan in place, say if the patient's going for surgery. The mainstay of management is you'd want to supplement those clotting factors that they're deficient in. DDAVP, which is also known as desmopressin, and it causes the release of von Willebrand's antigen to sort of stimulate that clotting cascade. Tranexamic acid is also used if they have excessive bleeding. You may also have seen it in treatment for menorrhagia, just to prevent heavy blood loss. Okay, von Willebrand's. It's the most common hereditary coagulation disorder, and lack of the von Willebrand factor essentially means that you have an increased risk of bleeding due to what's in the slides. It usually presents with mucocutaneous bleeding, menorrhagia, also positive family history is really important because it is inherited, and mucocutaneous bleeding such as GI bleeding or epistaxis. Most patients have type 1, type 2 and 3 are more severe. So investigations, the main thing to note is they would test positive for the VWF antigen. So that is the main diagnosis. But the APTT, whether it's normal or prolonged, depends on whether this factor 8 is deficient. And compared to thrombocytopenia, this would have a normal full blood count. And management is similar to haemophilia. Combined contraceptive pill to reduce bleeding, menorrhagia to treat that. Plan in place, desmopressin, mainly supplementing this lack of the von Willebrand factor. And in extreme or acute cases, where there's lots of bleeding, you'd want to do a platelet transfusion. Okay, so vitamin K deficiency. So it can result in these factors being deficient, and it's really important to learn these as they can easily ask them. And I thought it would be useful to refresh vitamin K deficiency because it may come up in other topics as well. So what vitamin K does is it gamma carboxylates all these factors, and therefore a deficiency in vitamin K would mean these factors aren't activated, so the clotting cascade fails basically. And then the treatment. So yeah, it's mainly caused by malabsorption. This is quite common in ITU patients if they aren't given vitamin K supplements. Or also to note, you see where medication comes in, really important if they're on warfarin, because that's a vitamin K antagonist. So you'd have a prolonged PT and prolonged APTT. The most important thing to note is the PT would be prolonged, so you can distinguish it from the others, and you'd also be deficient in vitamin K from blood tests. And essentially you would give vitamin K and see if the problem corrects. So symptoms and signs, as you can see, they're all quite similar, even though I've separated them, but the same idea is behind them. So failure to clot and excessive bleeding. Bleeding in potential spaces, such as intracranial bleeds, hemarthrosis, that's more common in haemophilia, whereas mucocutaneous bleeding, such as those, are more common in the others. Okay, so history, it's important to ask about all of these. They're all quite key to specific history. Past bleeding episodes such as excessive epistaxis, iron deficiency, ask if they're feeling tired or irritable. Menstrual history can be quite important, say if they've always had heavy periods. Family history is key, as a lot of these are inherited. Drugs, including aspirin and warfarin, you'd want to check for. Bruising, as we mentioned. And immune disorders, such as marrow failure or suppression, which can lead to thrombocytopenia, and things like that. Okay, so investigations, I've broken it down into these as you'd want to ideally present it in an OSCE this way, so it's good to see it separated like this. So yeah, most of self-explanatory. Again, ruling out other things. So if you suspect haemophilia, then you'd also want to do a von Willebrand's because they present quite similarly, so you want to rule out von Willebrand's. Platelet function studies would be further investigation if the platelet count is low to suggest thrombocytopenia and things like that. Okay, so differential diagnoses. These are all quite important, and I've mentioned immune diseases and medication, but also something important to note is child abuse. So if a child comes in with multiple bruises, it should always be on the back of your mind, and not just to go straight for a hemorrhagic disorder. So always think about that and ask more. So some OSCE tips interpreting the results. So I've kind of broken it down into causes of prolonged PT, which is vitamin K deficiency, and as we've said, warfarin can also cause vitamin K deficiency, and liver disease as well. And then causes of prolonged APTT are deficiency of those factors, so haemophilia and von Willebrand's. You want to take a specific history as well, which is what we've just gone through. So here I've done a basic summary of everything, essentially going through the investigation results you get and what you'd be thinking. So yeah, I think it's quite helpful just to break it down because it can be quite confusing. Okay, so some summary questions. Haemophilia B is a deficiency of which clotting factor? So we're going for B, not A. So it's 9. So as we've gone through, A is 8, B is 9. So what is von Willebrand's disease? Again, think about coagulation or platelet disorder. Okay, so it's a coagulation disorder. Remember that von Willebrand's and haemophilia are both coagulation disorders. Platelet is thrombocytopenia. An acquired platelet disorder is vitamin K deficiency. So question 3, last one. What factors are affected in vitamin K deficiency? So it's really important to learn these as they can ask. Yeah, I've also put here, I find it easy to say the numbers instead of the Roman numerals. So it's 2, 7, 9, 10, and then protein C and S. And you get a raised PT and raised APTT, so both will be affected. Okay, so I hope you found that useful, and yeah, thank you for watching.